Welcome, everyone, again. Thank you so much for being here. Today's webinar is titled Recovery-Oriented Documentation Using Hope-Centered Language in Supportive Housing. We are going to talk a little bit about what that looks like, and before we get there, my name is Dr. Crystal Sosha. I'm one of the Senior Training and Consultation Specialists here at the Rutgers Department of Psychiatric Rehabilitation and Counseling Professions. I am also joined by my colleague, Dr. Emily Bands, who will be here to assist throughout. If there's ever any questions, please don't hesitate to reach out to either one of us throughout this presentation. So, want to just start again by recognizing that the words that we choose, our tone, our body language, both our verbal and our nonverbal, even our silences matter. So, we'll talk a little bit about what that looks like and how our language can build hope, trust, support, and how we can perhaps sometimes unintentionally reinforce stigma or a power imbalance. So this webinar really invites you all to pause and reflect. What are we really communicating? How might our words be experienced by others? And how can we use language as a tool for supporting someone's dignity, for being compassionate, and ultimately supporting their recovery? So again, welcome. Today's webinar is hosted by DBHR through the Washington State Healthcare Authority. This is an interactive training, and we do encourage you to ask questions and participate throughout this session. Feel free to use the chat feature at any time. A note about artificial intelligence. Please note that the use of automated note-taking bots or similar tools during Washington FCS events or meetings requires prior approval. Unauthorized use of such tools is prohibited to ensure the privacy and confidentiality of all attendees. Also, any recording that is created through AI is not recognized as an official recording of this session. We reserve the right to exit trainees from the training if they are using AI to take notes without prior approval or using AI to record the session. Please note that materials and recordings will no longer be emailed to participants. Materials will be uploaded to the chat during today's session. We'll share a PDF version of that file, and a recording will be posted on the FCS YouTube in about 2 weeks or so. A few other training basics. Please connect to audio and mute your audio throughout this presentation. You have the option to use the chat throughout this presentation. Your video should actually be in this session off, so we do not see you, but we can hear you and engage with you in the chat. So if there's ever any questions, comments, concerns, feel free to use that chat. I see some of us are already sharing where we are joining from, so welcome. Before we get started for today, just want to think about a word. So think about a time when someone's words had an impact on you in a professional or healthcare setting. So this could be helpful, unhelpful. It could have been positive, negative experience. Put one word in the chat. Any experience that comes to mind just in this moment. Was it empowering? Was it dismissive? Was it encouraging, judgmental, validating? Think of one word to describe whatever is the opposite of validating. Maybe invalidating. Yeah, dismissive. Think of one word that describes how that interaction made you feel. Gaslit, degrading, minimizing, indifferent, mad, a statistic. Some of us perhaps validating, less than, unsafe, a number. Yeah, maybe you're someone who sees a provider kind of on this like automated, robotic, going through the motions, asking the questions next, 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 barely get a minute in, appreciate to be acknowledged, ignored, unheard. So we've got a mix, and maybe some of us are recalling the more negative impacts, and some of us are recalling maybe a standout experience that was different and validating. Tell me, what was it about those experiences for either perspective? What was it about that experience? And without, again, share what feels comfortable for you, but what was it about that experience that led you to feel that way? Just take a few moments to share if you feel comfortable. Thank you for sharing that. Being told that my miscarriage was just 1 in 5. So it really highlights that feeling like a statistic. Seeking medical attention with a past history of substance use and getting the same care as other people, or not getting the same care as other people. Maybe for some of us, we felt empowered. Some of us had to repeat themselves, plead for assistance. Yeah, there's this like extra layer of advocacy that has to come in or not being heard. Maybe it was the last doctor's appointment. Maybe it's the last time you decide to see that provider. Maybe that was the cherry on the sundae. That's it for me. I've really noticed how this person talks to people and how they specifically treated me, and I don't feel comfortable going back there. Yeah. So again, there's so many experiences that we all go through. We are, again, likely seeing a variety of providers ourselves. So think about the people that we're working with who are doing the same thing and experiencing the similar layers of being dismissed. Certain terminology feels valued in questions about ethics, for example. Yeah. Being asked for my pronouns feels empowering and supportive. Yeah. To know that someone really cares about your whole identity and who you are. And it takes a few, I mean, it really takes not even a few seconds to ask a question regarding pronouns, to ask a question about how you like to be addressed, to ask a question about your experience, to be curious. And so a lot of this webinar today will remind us that language is rarely neutral. It carries meaning, it carries emotion, it carries memories. And so keep in mind how even our own experiences are perhaps bringing up some discomfort and frustration and sadness, and recognizing how the words that we might use when working with individuals is also equally, if not more, important. So thank you for engaging in that with me, and hoping for those of you who may have had difficult experiences that we were able to connect with providers that do make us feel seen, heard, valued, and important, because that is just so critical in seeking help. If we don't have providers like that, we are likely to skip appointments or decide, I don't need to go to that provider anymore. I feel okay. Really on account of our own experience that really shifted our thoughts about going. So, with that being said, I want to talk a little bit about what we'll cover today. So, today is all about understanding and defining recovery-oriented documentation, what exactly that looks like, and why hope-centered or hope-infused language matters, specifically in our supportive housing settings. Many of you are likely joining from or working in a supportive housing setting, and this is applicable really beyond that, but tailored to you all specifically. We'll talk about some of that hope-centered, strengths-based language, while also noting some of the common documentation pitfalls in language that might be more harmful than helpful. And we'll take some time to just go through a few examples together and explore how we can really honor a person's autonomy and dignity. I'd like to also mention that throughout this presentation, we really want to be mindful of someone's culture and their whole identity, as well as using a trauma-informed lens. So we know that the people that we are working with have likely experienced some form of a traumatic experience. And so we want to be able to be mindful of our approach to make sure that we are ensuring safety and we are making the person as comfortable as possible. Sometimes we cannot guarantee safety, but we can guarantee our ability to be kind, to be present, to be open, to be curious. So doing our best to come from that lens. I also want to note that language does change over time. So language is dynamic and it evolves. We may not always get it right the first time. And so taking some time to pause, correct ourselves, apologize, and make sure that we don't make that same mistake again. Because those, again, think about your own experiences. One sentence could impact you forever. And thank you. Emily just shared the presentation in the chat for you to access that. So we want to just get started. Really in framing this session is through a psychiatric rehabilitation lens. So here's a fun pop quiz, not graded. What is psychiatric rehabilitation? How would you define psychiatric rehabilitation if you could in your own words? Honestly, no idea, and that's okay. Therapy, meds, keeping a regular schedule, going outside, having a healthy support system, addressing the psychiatric problem actively, bringing someone closer to the recovery goal. Maybe we've never heard this term before specifically. Healing an invisible wound with steps. Ooh, I like these. So we'll take a moment just to define that because I think a lot of the framing of this conversation is through a psychiatric rehabilitation lens. So when we're thinking about psychiatric rehabilitation, we also like to talk about the goals of psych rehab, or you'll see this kind of shortened version PSYR, psychiatric rehabilitation. So psychiatric rehabilitation really is the philosophy where you believe that someone has the ability to achieve recovery, to improve their quality of life, and to successfully reintegrate into the community. So think about what recovery might mean for you or for someone that you're working with. Oh, I see another example addressing symptoms that create barriers to moving forward and supporting through learning how to manage or adjust to grow. Yeah. So a lot of psychiatric rehabilitation falls into these three goals. So recovery, thinking about optimism for the future. So we, as helping professionals, are often instilling hope. We are someone who sees the best in the person that we're working with. We are someone who is supporting this person in achieving a satisfying, enjoyable life, whatever that looks like for them. A satisfying life for me might not be the same as it is for you. But this is really the distinguishing goal of psychiatric rehabilitation. It's a process of empowerment where we help individuals with mental health conditions to gain control over their lives or to feel like they have a sense of autonomy. They can develop skills and tools to reach their goals and to live in valued life roles of their choosing. So that is one of the key elements here. There's, of course, no single path to recovery, as we know. Everyone has a different journey, and recovery is not linear. So you'll find that each person has a different way of achieving their goals. The second goal we talk about is quality of life. So, how a person feels about their life, that kind of subjective measure or subjective sense of well-being. It can be objectively measured, like how satisfied or unsatisfied they really are. Think about if they're engaged in things like education, what their income is, their financial stability, their health status, their connection to friends, community, loved ones, access to necessities. All of those things impact a person's quality of life. And then community integration. So helping the individual to really live independently in a community of their choice. And it's not only simply living, it's like really being integrated into it, as the name sounds. So it's, let's say, using the community to access resources. Think about your home, your workplace, your local shopping center, the coffee shop down the road where you know the barista's name and they know your regular order. Like really being so immersed into the community that it gives a sense of meaning and purpose in life. Okay, so just wanted to name that before we get in. Now, we're going to talk about recovery-oriented language. I just briefly highlighted what recovery looks like, but what is recovery-oriented language to you all? How might you define recovery-oriented language? Strengths-based, yeah. Moving from deficits to strengths. Maybe moving from quote unquote illness to the whole person. What else? Meeting a person where they're at. Yeah, kind of this person-centered. Maybe it's motivating. Yeah, connecting to that idea that, again, we are instilling hope. We are someone who is helping this person along their journey. Collaborative goal making, yes. Strength space, validating the person and their story. Yeah, a lot of what we're doing is paying witness to someone's story. We are witnessing their narrative. We are hearing what they have to say to us. And maybe they've told another person 25 different times. I will always remember being someone's 26th case manager. And this was some time ago, but think about how much turnover that is for someone to have to relive and retell their story over and over and over. So we're, yeah, validating and paying witness. Empowerment and hope, trauma informed, modeling. Yeah. So recovery oriented really recognizes that each person is and is capable of achieving recovery. It conveys a lot of hope, the possibility, the option for growth. It respects autonomy. It is really compassionate and care driven. We also often talked about people not being defined by their mental health condition, and sometimes individuals really connect with their identity in that way. And so mirroring the language that someone is using is important rather than saying, no, you're not X, Y, and Z, allowing them to use the language that they feel most empowered in. And at the same time, we want to be mindful of avoiding labels. So this sometimes takes a little bit of self-reflection. Do my words convey optimism and belief in recovery? Maybe, we might have moments of frustration. We're human, and maybe we feel some, again, discouragement or perhaps sadness. We're struggling with working with someone who's been really trying their best to achieve their goals. And sometimes we just want to be extra mindful of, are we still conveying that optimism for them, or are we also feeling frustrated? Am I supporting their autonomy? Am I reinforcing perhaps their need to rely on me frequently? Am I creating partnership and collaboration? So things to keep in mind. But we're going to talk about recovery-oriented language in terms of what not to say or do first. So this is probably not new to many of you all, and maybe there's some things in here that maybe perhaps you didn't realize, or there's some things to add. So we're going to take some time just to go through the what not to do or say before we go into the what to say or do. So, one important thing that we often talk about is person first language. So, not labeling people or defining them by their diagnosis. So, this might look like they are mentally ill. Again, some individuals really do connect with their disability identity. And so, it's important for them to use the language. So, if that's the case, mirroring the language that they choose to use. We, again, many of us emphasize the strength space, so we are not emphasizing limitations or what's wrong. A lot of our trauma-informed approach, really moves from the what's wrong to what happened to you, also to how did this person learn to survive? So understanding that that behavior comes from somewhere. Avoiding using patronizing, condescending, or judgmental language. Sensationalizing or infantilizing. Sometimes, depending on a person's diagnosis, we might infantilize them or assume perhaps that they might not understand what we're saying. So being mindful of not treating a person as an infant or a child, and also being mindful of the language that we use to describe them. Not portraying success as superhuman. So recognizing sometimes we'll see this, really throughout the media, like the um, it's actually identified in some communities as like inspiration porn, where we are identifying that this person is, again, a superhuman. What an incredible thing. So, how demeaning and again, infantilizing that could be. Making assumptions based on a person's diagnosis, age, disability, ability, appearance, race, gender, identity, all of those things arguing with someone's feelings or perceptions, kind of coming from the, no, I know better because I'm supposed to help you, and so I know what's best for you. Yes, I'm also, thank you for that cue. I always say mirroring the language is so important. Changing the way that someone identifies when we're repeating back to them is annoying, yes, dismissive, um, frustrating. Maybe we don't feel heard when language is being changed. If you identify as autistic and someone is saying, no, you are a person with autism or you have autism, mirroring the language that is being said is more important than anything. Minimizing experiences to focus only on symptoms. So there's so much more than a person's symptoms, so understanding their whole experience. Jumping in or speaking for someone or rushing them. So sometimes, again, we might have like an urge to jump in or to problem solve or to fix or to correct. And so letting someone take up space, it's okay to wait for them to finish what they're saying before we jump in or interrupt. Not assuming understanding without checking. So we may have an assumption about the person that we're working with without really understanding the facts. Design plans without meaningful consultation. So this is, again, that collaborative piece, making sure that we are connecting with the person, especially when we're creating goals. We are not the person who should be driving a person's goals. They are the driver. We are their co-pilot. We are here for the journey. We are working alongside collaboratively. Assuming you know what's in their best interest, we sometimes might jump into the action stage of change. And we are often one step ahead of someone. And that could be, again, quite dismissive because a person's not quite ready to think about maybe the skills they're about to learn. They're still processing whether they even want to move forward with making this new change. And thanks for that, Q. Q said, I understand that it can be uncomfortable. My wife likes to reclaim the term schizophrenic, which I really struggle with, but it's her label and her identity, so I respect it and speak the same way. Yeah. Right. There was, a really big push for person first language until we recognized that people also have the power and choice to choose how they wish to identify themselves. And so, if we can respect that, there's kind of like these two movements, those who really connect with their what might be called like illness or disability identity, or people who, really want to feel empowered and say, this is only a part of me. And wherever that person stands, it's not our place to correct or to overwrite, but again, yes, to mirror the language. And while it may be uncomfortable for us, if we learned in school or in training, no, you're supposed to use person first language. Yes, and sometimes there's situations where individuals prefer not to use person first language. Think about even in recovery, when individuals are attending recovery support groups, they might identify themselves as an addict or alcoholic, and perhaps language like that to us might feel uncomfortable. But again, mirroring the language really helps this first person to feel connected to the community and feel connected to the identity. Thank you for that. So, some words that can cause harm, and I have a resource at the end. This is a really great, there's a good amount of pages that talks about recovery-oriented language in different settings with different populations. And so I'll have that resource at the end. So, some of this is from there. And I want to mention language that can cause harm because words really do matter. And this is really only a few. But recognizing even how we're documenting how using this language could cause harm. So this might include words like manipulative, grandiose, passive aggressive, in denial, self-defeating, oppositional, attention-seeking, borderline. Again, just to really name a few. But you might see this or hear this even with the people that you work with or in the community who are using this language. And so, doing our best to avoid any problematic or sensational language, these words are in some ways like alienating individuals, they're reinforcing stigma. And so, we want to be mindful of using language that's supportive. This is so true. I even think about as I was developing the presentation of how we talk about suicide. And so, oftentimes, again, a good example of how language around suicide has shifted. So, instead of saying unsuccessful or incomplete suicide, can we call it a suicide attempt? Instead of saying this person, quote unquote, committed suicide, which really indicates or correlates to this idea of like committing a crime. How can we simply say this person died by suicide, this person ended their life? So think of the language that we use, maybe with someone who is frustrating us or is maybe really having a hard time connecting with us. And now we are using language like manipulative or attention seeking. And so I often think about how attention seeking is actually connection seeking. How is this person trying to seek reassurance and comfort when they're really distressed? And how could we describe their behavior rather than putting a label on them? And we'll talk about that too. Um, yes, support seeking. Yeah, I like that too. Yeah, I always say connection seeking, or finding ways to build connection, looking for additional resources. There's so many ways to describe that behavior. Like what exactly are they seeking? Each behavior has a function, so how can we describe it factually? Like if there was a video camera watching this person and we're typing our note, how can the video camera describe the behavior? So the video camera is not going to say manipulative. It's not going to say in denial. It's going to describe the behavior that is happening and how they're communicating with us. Instead of that, we want to talk about what to say or do instead. So, putting the person first, again, depending on how this person chooses to identify, can be helpful. Emphasizing their strengths, skills, passions, and abilities. What are some of the things that they're doing well? What is important to them? Using hopeful, optimistic, recovery-focused language. We'll talk more about this too. Ask how they would like to be addressed. Again, it takes all of 1.5 seconds. Use plain language and check a person's understanding. So, again, not in a infantilizing, childlike way, but think about when you go to a primary care provider and they're throwing out every acronym that they use, and you're like, oh my gosh, I only know acronyms in supportive housing, and that's already so many acronyms. Think about how we can maybe avoid using acronyms or avoid using clinical language, and making sure that the language that we're using is being understood by the person that we're working with. Validate experiences. A lot of the work that we do is validation and encouragement and positive reinforcement. Allow time and space for expression. So, again, instead of jumping in and jumping to conclusions and filling in the space, sit in the silence more. Ask if they feel ready to make decisions or want support. And this is a big one, again, to that collaborative piece. A lot of what we're doing is surrounded by shared decision making. We should be making decisions collaboratively. So we are moving from the doing for to doing with. We're working alongside this person. Involve a person meaningfully in care, treatment, and planning. And again, being mindful of identity, autonomy, and dignity at every age for every person for like across the developmental lifespan. So again, helping this person to really ask strengths-based questions, helping this person understand what would help you get closer to your dreams. What might be steps forward? What are you looking forward to? What is important to you? And I'll share more examples in just a moment. Is there any other things that perhaps you all do that's maybe not listed here that helps you to be more recovery oriented? So more strengths based. What else do we do? Validate without expressing pity. Yeah. And that's such a good one. Really empathizing with this person and connecting with them on a more deeper, intimate level. Remember that people had whole lives before they came to us. Yes, we are only seeing a small segment of their life identity. Right. The person that is in front of us is likely not the person they were perhaps 5, 10, 15, 20 years ago. And so, yes, thanking them for their story, showing compassion. A lot of the work that we do is recognizing the grief and loss that comes with identity. Oh, yeah, I love that. As a peer, using mindful and relevant self-disclosure. Me too. Yeah, really connecting on a human level. Great. Thank you for those examples. And we'll talk a little bit more about some other ways to use this in our work too. So, we want to talk about how actions speak louder than words, and wanted to emphasize how research specifically shows that communication is actually only 7% verbal and 93% nonverbal. The ways in which we communicate someone is really more impactful in the nonverbal lens. And when we think about nonverbal communication, what that looks like is 55% body language, and the remainder of that is your tone of voice. And so while that still is verbal, think about just the ways in which we are delivering a message, the ways in which we are allowing time and space for someone to think and ask questions and respond, the importance of silence in our interactions, Am I being authentic? Am I demonstrating empathy with this person? Am I being transparent and sincere? Remembering that your body language really shows communication. And this time of year, it's extra cold. We might be bundled up in our scarves, hats, gloves. I've got a blanket that I'm sitting on. Think about if I was wrapped up in a blanket doing a presentation, how that might come off to you all. Or if I sat here crossed-armed, how that might impact you, that I might be a little guarded or defensive. You read my mind, Jessica. Yeah, keeping our body language open. Don't sit with your arms crossed while talking with clients. Yeah, and sometimes depending on the environment, how space has an impact, like how can we really be attuned to this person in front of us, mirroring their body language too, facing them, using an open stance. Think about a provider that you've been to and they're sitting on their computer and they're like this and they're not even looking at you. How that could impact how you feel about the visit. Guide on the side, not a stage on the stage. Yeah, eye contact. Right. Maybe again, checking in with what accommodations someone needs. How can we make the environment more supportive for this person? What makes them feel safer? What supports or assistance might they need to achieve their recovery goals? All of these things matter. If we can be more attuned to those pieces, it could really have the world of a difference. So, to talk more about words and documentation, we're going to jump into intentional service delivery. So, what is intentional service delivery? I told you I'd be interactive. I'm keeping you on your toes here. Planned, tied to goals. Yeah, creating a safe environment for folks. Keeping an eye on the big picture of the client's goals, not letting ourselves be blown around by the day-to-day. Prioritizing user experience and empathy. Part of this is active listening. Yes. I will also say just a reminder of the language that we use to describe individuals we're working with. You might say individual, client, consumer, user, participant, person served, and your agency might require something different too. So even think about that. I think it's a way of goal-driven environment of the client's place on their journey. Yeah, great. So when we're thinking about intentional service delivery, the essence of it is aligning interventions with the person's needs and goals. There used to be a time where services were not intentional. We'd kind of show up, we'd chit chat, we'd have a cup of coffee, we'd check in about the week. And while we still do that to build a relationship, it is much more goal driven. So we use intentional services that are purposeful, deliberate, planned, goal directed, and really tailored to the person's stage of change. And that's so important as we are, again, instilling hope in someone. Before each interaction, it can be helpful to ask yourself, what goal are we working towards today? Where is the client in their stage of change? What intervention aligns with their individual service plan or whatever goal or treatment plan that you use? How will this visit move them forward? So progress can be meaningful. It doesn't have to move mountains after each visit, but what can I do today to help this person move progress forward? And thanks for that question. Yeah, open to everyone attending here. How do others refer to their clients? Q says they've always referred to using the word client. For permanent housing folks, I try to say guests when I'm doing shelter work. Oh, yeah, some people enjoy tenant. Yeah. Here in New Jersey, we use language that's often seen as client or consumer, tenant, resident, person, individual. Some agencies prefer person served. If there's any other examples, feel free to throw in the chat. But again, emphasizing that intentional service delivery is no longer just a random check-in. It's not as simple as a one size fits all. They're very much strategic and person-centered. So when we're talking about these services, we want to be mindful of how our words matter. And I think we all are here for a reason. We know that words matter. We've experienced things ourselves that have impacted us, maybe negatively or positively. And so the words we choose reflect oftentimes our attitudes and our values. So it's important to be respectful and non-judgmental. Language can shape meaning, expectations, and actions. Think about how you might engage with the person that you're working with. And some of you all had shared earlier that an experience you had led you to no longer see that provider. So again, language shapes actions. I see again similarities around language, guests, relative. People should be seen as individuals first. Again, this is really embedded in much of the literature and with the caveat I shared earlier. And our communication should really reflect unconditional positive regard. So, again, this is not new to us, but we want to be mindful of how language is heard, so how we're expressing language, and also how it's read. So when we're documenting, we want to reflect just as much as of a positive and hopeful interaction in the note as we do in real life or in our day-to-day experience and encounters. So again, being mindful of how language is read and heard. If someone pulled out their chart, how would they feel about what you wrote about them in the document or in the progress note? Would it reflect the session? Would it be free of non-judgmental language? Being mindful of its impact on health and well-being, how language, again, might dissuade someone from seeking services. The meanings and messages we promote. Think about our own values and beliefs. Are we instilling our values and beliefs on the person that we're working with, or are we coming from a neutral stance and allowing the person to make meaning of their own experience? Be mindful of what our words reveal about our attitudes and how language affects engagement with supports. So we might, I'm thinking about, let's say you have um, a family member in which you might have a conflict with, and you're working with someone who has um, a current conflict with a family member, and maybe we're kind of sharing our personal experiences, and it's impacting their connecting with their family member because you've experienced it too, and maybe it's not the feedback this person was looking for. So, how can we help this person find their own path to what they want from this relationship rather than assuming that we might know, again, what's in their best interest? Of course, as we shared, there is some helpful and supportive and tasteful self-disclosure that can be beneficial. And ultimately, how are we making sure that this person is kind of leaning on themselves to make their own decisions and choices? Okay. So, some reflective questions that could be helpful. Again, what else am I communicating? If I'm writing a note and I'm using maybe some of the harmful language, how might this be received? Am I conveying hope and commitment? Do I communicate belief in recovery, or is my note expressing some of the frustration? Could my words create a power imbalance? Again, if I believe that I know best, is that being kind of infused into some of my documentation? So keep those things in mind. So I want to jump into, again, we've spent a little bit of time of understanding words and language and why it matters. And so now we're going to talk about how this really shows up in documentation with some more specific examples. So what is the purpose of documentation? Why do we spend maybe several hours, minutes a day documenting our encounters with the individuals that we're working with? Continuity of care. So the government keeps sending us the money. Just kidding. If you don't write it down, it didn't happen. Yeah, if it's not documented, it didn't happen. I think that's the message that is drilled into our brains. Compliance with funding requirements, right. In order to continue to receive funding, there is some truth to that statement. Yes, we need to be in quote unquote compliance. Tracking progress. Yeah. Covers all the bases for yourself and who you're helping. Yeah. We often talk about making sure that we are also documenting attempted outreaches. So the times where you even tried to connect with someone is important to document. Because again, if we did not document our outreach attempt, it did not happen. Shows the work that we do with the person. Yes, that is the most important part. What are we doing with this person to help them achieve their goals? Right, keeping ourselves accountable to the work, tying interventions to the goals, telling the client's story, to transcribe the story for ourselves and other community members that may read it. Right. Yeah, so we want to be, again, mindful of the language that we use in our documentation if we are accurately reflecting the person's story. So we know that documentation in supportive housing is really more than a requirement, though. It is, yes, a funding requirement, and at the same time, it's a reflection of how we see the people we serve. It is a communication tool. If I'm off of work and Emily's covering me, I want to make sure that Emily understands exactly what I did with this person. And it's a narrative of someone's life and recovery. So I like to think about if someone read only your notes, what would they believe about this person? What would they understand about this person and your last encounter with them? How is that note telling their story? Is it accurate? Is it inaccurate? So it's funny, this picture, when I searched for a picture, these binders showed up, and I remember, I don't think any of us are using binders anymore, but I remember starting in supportive housing, and there was still so many binders in the double locked cabinet that was locked behind another door. And so pulling out a person's binder and kind of shuffling through all of their goals and making sure that we are, up to date and in, again, compliance with our funders is very important. And how are we talking about this person, not only in our note, but to other people around us? How are we describing the person that we're working with to a coworker? Do we really truly believe that it's important to not describe this person with a label? Are we only saying that for documentation and then we're going off and telling our coworker how quote unquote manipulative this client or person that we're working with is? So not only are we being mindful of what we say and how we say it, how we document, but also how we talk to other people about the people that we're working with. So in our progress notes, again, we talk about it as a record for communication, a bill to the funder, and we also recognize that there's so many challenges within that. So just again, reiterating the importance of covering all topics of the outreach or outreach attempt, maybe being concise with relevant information. This is so hard because sometimes we're like, how much is too much and how much is not enough? Do I have to say everything, or is there a way to be concise and detailed without overdoing it? Maybe it's helpful. Some agencies really love using quotes, so like actual language that the person shared with you. Always following up on issues. If last week someone shared, that they weren't doing too well, and maybe you're feeling frustrated and it's showing up in the document. One, being mindful of how you're reporting the issue that they're experiencing, and two, just double checking on how they're doing. The bill for the funder, which we talked about, if you're using individualized service plans, we are documenting the services that are outlined there and making sure that there's a clear connection. So, how can we continue to seamlessly instill hope for this person across their time with us? And again, we recognize some of the challenges with progress notes, so just wanted to name that too. It's not as simple as it sounds to document. It does take a good bit of effort and a good bit of thoughtfulness. So making sure that we can still meet those demands while also caring for ourselves in that process. Some helpful tips that we like to talk about, especially in documenting, is the irony of being clear and concise. Your agency might have more requirements on that. Using person-centered language, avoiding judgments, thinking about the quality over the quantity, avoid transcribing a whole encounter. It may not necessarily have to be written out in the I said, then he said, and they said, and she said, and we talked about, and it doesn't necessarily need to be every single detail, but again, checking in with your agency's requirements, really just describing the facts. If we're also talking about, again, about a person's behavior or feeling or emotion or action, avoid those vague descriptions. So when I say, how can we be behaviorally specific? It can be helpful to use language like as evidenced by. So instead of saying client was upset or angry or whatever that feeling might be, what tells us that this client was upset? Were they upset to you? Or what told you that they were upset? Maybe they were tearful, they were crying. Maybe you noticed their fists were clenched. Maybe you noticed they, I don't know, picked up a chair and threw it. Like something observable should go there. And when I think about, again, like how can we really be recovery oriented? Think about these questions. If I'm out or sick, someone will need to pick up where I left off. Can they understand what I've been doing based on only my notes, or am I maybe leaking in some judgment in some of my notes that it might impact them too to work with this person differently? Would the funder, would you, would a family member, would you pay for a family member based on this note? Yes, I love saying appears, right? It really is our opinion of what we're noticing. So client appeared frustrated as evidenced by. Thank you for that. How would I feel if this were my record? If you were looking at this chart and this was you, how would you feel if you read the note in it? And I think that is really the point to drive home because if we're feeling some discomfort or this quite doesn't quite hit the mark with our encounter, how can we really be more thoughtful in describing our experience with the person? So there's so many different ways to talk about, let's see, I'm going to skip over a slide here. To talk about language, there's so many different quote unquote buzzwords, and again, agencies might prefer language for you to use. You might say things like ongoing support, provided continuing education. You're will continue to monitor. You're coordinating, you're advocating, you're following up, you're connecting, you're referring. You are ensuring linkages with community resources. And that's a great example. So using declined instead of refused, right? What does it mean to refuse? And also, what are we doing that contributes to the reason for this quote unquote refusal. There is also something to be said about how we might be showing up with someone or what's happening for this person that impacts their choice too. We also like to talk about interventions. Oh, I'm going to skip, let's see. I might skip this one, but you'll have access to it. But I want you to just consider when you're thinking about stages of change, how it could instill recovery language versus how it might, again, almost impose your own values or have some bias in the note. If kind of goes with that example that was just shared, if the person is not interested in working on a goal, maybe they're more pre-contemplative, can it be more helpful to again maybe quote them, use that language rather than saying refused or rejected or dismissed you. Maybe you had a felt experience, but mirroring their language can be helpful. Yes. When a person's more contemplative, so they're kind of ambivalent or uncertain, think about how we can express their ambivalence too. We don't need to describe that they are denying, refusing, dismissing us. They're not quite ready to work on that goal, so they're expressing ambivalence. There's some uncertainty. When someone is more in that action stage of change, they might be more motivated or ready to work on a goal. So now we're noticing the motivation building. When someone's more in that kind of end of like achieving a goal, they're working on maintaining that goal. How can we continue to instill hope by showing they're continuing to work on that goal? And we're collaboratively working with them and we are identifying ways to navigate triggers. I even think about in the ways in which we define relapse, which is in some ways like a quite a stigmatizing term for some individuals. Some people, again, might choose to identify with that word. Instead of saying like client relapse, could we say client re-engaged in substance use? And we discussed, ways to cope with triggers that come up in the future. So, like, what a shift in like a very small shift that could make a difference in a person's note and lived experience. So, we have some other examples here, and this can be helpful for yourself as well as for supervisors, thinking of progress notes like a receipt or a restaurant bill. Or again, I like the example of a video camera. If a video camera was watching what actually happened, being very specific and objective, like think of again what was ordered and why. And really being able to track that progress. I'm hopping over a few of these because I want to get into the recovery-oriented documentation specifically, but this could be a great quick checklist for supervisors. So, with that, hopping through, taking a moment to really connect the pieces. So, we spoke about recovery-oriented language, and now we're going to talk about how this shows up in documentation. We've really spent a good bit of time understanding how recovery-oriented documentation shows up. So we're reflecting a person's ability to grow, change, recover. We are centering their lived experience and their goal and their voice. We're highlighting their strengths, again, very much a strengths-based approach. And we are honoring their autonomy and choice while at the same time, again, meeting compliance and funding standards. When we talk about hope-infused language, again, we talked about psychiatric rehabilitation, and a lot of this really is embedded within psychiatric rehabilitation. So, hope infused or hope centered language uses empowering, strengths based, recovery oriented wording. So, you'll hear recovery oriented, hope infused, hope centered, recovery centered, all really connecting to the same experience, but or same meaning, but wanting to validate a person's lived experience throughout this process. So again, language might reinforce a person negatively, or it can offer space for growth. So when we talk about deficit-based versus hope-infused approaches, this word kills me to this day. Instead of a deficit-based approach like client is non-compliant, can we, again, behaviorally describe it? Client chose not to engage in the offered service at this time. Um, I saw the example of, again, maybe individual declined interest in working on this goal at this time. Non-compliance might, again, I mean, it does have a really negative connotation, and I think there's a lot of what we do that impacts this quote unquote non-compliance. Refused services. So again, how can we shift this to a more hope-infused approach? Maybe this person is still exploring options that feel aligned with their goals. Or if someone's saying poor insight, like what exactly does that mean? Can we behaviorally describe this? Can we say this person's continuing to build understanding of, or even simply saying like this person expressed fill in the blank. Client is resistant to support. I also don't love that word at all. Maybe client is exploring again what types of support feel most helpful right now. So when we feel or notice that we're using some of that deficit-based language, trying to shift to a more hope-infused approach. This also supports how we are going to work with this person if we are starting to notice we are in a field, of course, that has so much burnout and vicarious trauma. There's such a high risk for us to experience these feelings of discomfort and frustration. And when we notice that seeping in, being mindful of how we're talking about a person and how we're writing about them in their notes. So taking a moment to really reflect on that. And really highlighting this key shift. Instead of asking what's wrong, maybe exploring what would help things feel a little bit better. Instead of assuming this person is not compliant, again, how this plan might not be a good fit yet. Maybe there's other goals that this person wants to work on, and this one is not a priority just yet. A person's hopelessness, maybe recognizing, I hear how heavy this feels, and I'm noticing this impact on you. Maybe recognizing their strength. Instead of labeling and telling this person you have a problem with, exploring what skills have helped you before. So again, kind of leaning into that strengths-based approach. A lot of solution-focused approaches also do that. Like they try to ask, what's been something that's helped you in the past? What's something that's been positive about this experience? What's something that has supported your growth? So a lot of this is, again, maintaining some accountability while reducing that shame and defensiveness. So how might we shift from a deficit-based statement, client is unstable? How might we describe this more behaviorally? Client is exhibiting fluctuations in behavior. Yeah, maybe say a little more. What is that fluctuation? Depending on what is meant by unstable, could be labile. Sure. Maybe again, expanding. What does it mean to be labile? Client has experienced symptoms during session and was given tools to help with stability. Client then practiced these skills successfully. Beautiful. So this might look like a combination of all the things you're sharing. Client experienced increased symptoms and utilized coping strategies discussed in previous sessions. You might want to describe the symptoms if it's helpful. You may not necessarily have to, but again, the shift of unstable or decompensating or failing to comply, or any, again, you name it on the deficit-based language, shifting to describe what actually are we observing. How might we change this one? Client is unmotivated to work. And while that might be a fact, what really tells us that? Client is focused on other goals at this time. Right. We're coming week after week after week, and client or person is not interested in working on revamping their resume. Okay, why are we still revamping the resume? Is there something else that is a priority? Oh, yeah, I love if we're using again the client's report, so client reported, client said, client stated, client shared, client discussed, experience reduced motivation to complete necessary life-sustaining tasks. Yeah, sure. And I think again, there's so many different ways to say this. I wrote client expressed ambivalence about employment due to past workplace stress. Yes, people always forget low motivation is a symptom, not an attitude, right? People aren't trying to be quote unquote difficult. I always hear like the words difficult and challenging. Well, what's actually happening for this person that's leading them to present this way? They are not trying to make your life miserable. They're not, even if we might feel that way. So having that understanding of this person is experiencing something really difficult right now can be helpful in shifting that language. Oh my gosh, yes, of course, no problem. Please share with your colleagues, of course. Some documentation pitfalls, again, we talked about the language before and how it harms, but recognizing how language can also be labeling. So when we use language like manipulative, lazy, will never, they're a chronic failure. There's an overemphasis on deficits. We're no longer including the person's voice, and now we are actually including our subjective opinions about this person. We are documenting because we have to rather than because it's a collaborative process. All of that impacts us. So we like to talk about how you can be the hope holder, which just sounds like so sweet. I just want to hold you in my hands. We carry the belief when clients or individuals cannot. We reflect strengths that individuals might not see yet. And so we are consistently holding this hope for someone. We are keeping recovery visible. We are their silver lining. We are the light at the end of the tunnel. Individuals may, I love this quote, clients may borrow your hope until they can reclaim their own. Like, please take my hope, borrow it, have it, take a piece of it for now. Some hope questions that can be helpful to ask. What brings you meaning? What gives you purpose? What helps you feel capable? What positive moments can we build into services? So, we're going to talk about in our last 15, 20 minutes here about this hope infused documentation checklist that we will share with you all. And so, this checklist covers all of the following. Language that conveys hope, it's person-centered, strengths-based. There's a connection to cultural responsiveness and cultural attunement, shared decision-making, so working collaboratively with this person, connecting to natural supports, so people in their environment. There's a wellness focus, so recognizing this whole person, using trauma-informed language, and again, that piece about partnership. So this is, again, something that we will share with you all at the end of this presentation. And um, Emily, if you have access to that, feel free to drop it in the chat. So the first one is language that conveys hope and belief in growth. So each of these have like some helpful questions to ask, and I'll provide some context too. So does my wording reflect belief in the person's ability to learn, grow, and recover? Did I highlight effort, progress, strength, and resilience? So instead of the client continues to struggle with budgeting, Again, while that might be a fact, how can you describe what the client is actively doing to work towards that? Or how can you describe the barriers that are getting in the way? So, client is actively working on building budgeting skills and identified interest in identifying new tools to help. So, using language that conveys hope is really the foundation of this. The second piece is person-centered and autonomy honoring language. So, does the note reflect what matters to the person? I personally enjoy the use of direct quotes when possible. That doesn't mean that you have to, record them. I mean, you shouldn't, but it doesn't mean that you have to get every single word that they shared. But sometimes I like to have a sticky note out if it's helpful for you. And if the person is okay with that, I often say, like, what you're saying is really important, and I want to make sure that I didn't miss anything. Would it be okay if I took down a few notes? And I'll usually catch a quote or two just to reflect in my note and really capture their lived experience and voice. Are the person's own goals, words, and preferences included? Did I document choices offered and how the person participated in decisions? So if I can at any point offer choice, or show how this person is leaning on their own autonomy, how they are being very much driven by their own intentions. That's so important to document. Strengths-based framing. Again, we keep talking about strengths-based language. So, um, does the note identify a person's existing strengths? We're almost, again, if you read this note, would you be able to see the things that this person is doing well? Is the description of the challenges contextual and respectful? And does the language avoid any deficit-based narrative? So, removing harmful language, being mindful of the ways in which we're labeling and shaming a person's behavior. So, you might say something like, maybe this person has been struggling to attend an appointment at their medical provider and they don't have transportation and they've been trying to find a way around it. Maybe you want to like name that despite transportation barriers. This person attended 2 appointments this month and demonstrated a commitment to their goals, for example. Culturally responsive documentation. So, did I include cultural, spiritual, or community factors? Remembering, how are we reflecting this whole person, not just the services rendered? So, does the note avoid any assumptions about a person's culture? Think about even something as simple as eye contact. For someone, perhaps eye contact is a sign of respect. For others, it's important not to have eye contact. For some individuals, it's hard to make eye contact. So, being mindful of not labeling this person simply because they're not making eye contact with you, but could you behaviorally describe this person? Maybe it's through noticing again, or it's through observation rather than they refuse to make eye contact with me. Well, what's that about? Like, let's be curious. Shared decision making and choice points. So, did I document the options discussed? Did I describe the choice the person made and how it aligns with their values? Maybe we reviewed 3 housing options and participant chose to remain in their current unit while exploring possible employment opportunities. Yes, yeah, exactly. Exactly, yep. Natural supports and community integration. And this is such a big piece. Recovery includes belonging. So, how are we making sure our documentation highlights a person's natural supports? Does this person, connect with their local? I always think of like your local coffee shop or your local library or the person that they live next to, the neighbor, the person across the street that they wave to each morning. How are we making sure that we reflect some of those pieces in our notes rather than assuming or stating that they're isolated or refuse to get out of their house? There's so many different ways that they can participate, and how can we reflect that community participation? Wellness focus. So, did I document multiple life domains? So, think of those 8 dimensions of wellness: physical, emotional, social, occupational, financial, environmental, spiritual, intellectual. Was trying to think of them all. Yeah. So think about how those 8 dimensions exist for someone. While we might primarily be focused on housing stability, how are all of those other dimensions being impacted? If I don't have access to food or the person you're working with doesn't have access to shelter or clothing, how are those things impacting their overall well-being? And maybe did you document these areas in their life? Using non-stigmatizing and trauma-informed language. So is the language I'm using neutral, respectful, non-judgmental? I'm avoiding pathologizing, labeling, I'm describing the behaviors. Again, if you can't observe it, you can't describe it. So if you're able to observe it, then describe it. What are you observing? Describe the behavior. That will avoid any character judgment. That will avoid any of the labeling, the shaming, the stigmatizing language, and really, again, leave some room for understanding unmet needs. How are you centering the individual's experience? So I wanted to include a few examples of this specifically. So each one connects to the other. So stigmatizing language, for example, might look like client is manipulative and attention seeking. How might you reframe that to client requested additional staff support on a few occasions today and expressed feeling unheard during earlier conversations? Again, you can say that in so many different ways, but thinking of a trauma-informed, more hope-infused, recovery-oriented reframe. If instead of client is dramatic and overreacts to minor issues, maybe client experienced a heightened emotional response to a conflict with a neighbor and reported feeling unsafe. For example, if you wrote client became aggressive and disruptive, maybe reframing that to client appeared frustrated, as evidenced by raising their voice and pacing during the discussion. Staff offered space and grounding strategies, and participant was able to re-engage after 10 minutes. So again, centering this person's experience, avoiding dismissive, labeling, stigmatizing language. And our last one is collaboration and partnership. So does the note reflect collaboration, shifting from staff instructed to, or staff told, or staff informed to staff and participant and client relative discussed? We worked collaboratively. We were able to identify goals that were meaningful and relevant for this person. Does it show that the individual is the driver of their plan? And so when we translate this again, just showing a few more examples, when we're moving from deficit-based to hope-infused, instead of saying client refuses to engage, maybe it's client expressed concerns about the current plan, or client is interested in exploring alternatives, or client is not quite ready to work on this goal and asked to work on something else. Like we could really expand that. Sometimes we feel stuck by the goal plan. And if that's the case, rewrite the goals. It's okay to change the goals at any point. Client lacks motivation. Maybe instead client reports feeling overwhelmed. Again, how are what we are witnessing a symptom of what's happening for them rather than labeling that? So maybe identifying strengths to support next steps. Yeah, thank you for that. See, I love how this moves away from personalizing behavior and reflects the client's potential experience. Right. So let's take a moment to practice these two. So let's start with example one. Client was non-compliant with medication and refused case management. I'm sure you have experienced a client who is not actively taking their medications. How might you be more hope infused or recovery oriented? For example, one. Ooh, yeah. Client wants further education on medication. Client expressed a desire to try other treatment methods. Client expressed this medication may not be best suited for them and described wanting to work on this independently. Right. Client is choosing to explore other treatments at this time. Client is reconsidering other possible options. Yeah. Maybe it's client shared concerns about medication side effects and chose to pause medication at this time. Maybe writer discussed options and client agreed to um, maybe connect with their medication provider. Okay. What about the second one? We kind of talked about the unmotivated piece, but how might you reframe the resistant part? What might you say instead? Ooh, love that. Strength base. Thanks. I see Sabrina said client was able to advocate for themselves and expressed they weren't ready to explore employment at this time. Yeah, client is instead focused on fill in the blank. Client wants to work on X, Y, and Z. And you could always say, like, writer intended to work on client's goal of seeking employment, and client shared that they are not interested in seeking employment at this time. Client expressed desires to stay away from workplace activities at this time. Client is instead focusing on other things, right? Yeah. Fill in the blank, XYZ, whatever that is. And I think in some ways, a lot of this is allowing this person to exist as they choose. We cannot live their lives for them. We may want the best for them, and we always will. And I think that comes with that hope infused and recovery-oriented perspective. And we have to honor this person's autonomy to say, hey, this goal is not working for me, and I'd like to do something else. Client is exploring options that are geared more towards his interests and goals. Right. Yeah, there's so many other things that this person is finds more meaningful. Client appears to be uncomfortable with his new surroundings. He appears to need time to build trust with provider. Right. There's so many, again, so many options and possibilities around how to say this. So when you find yourself trying to write non-compliant, think of me in your head and start deleting backspace, backspace, backspace. How can I describe this behavior instead? I'm writing resistance. I'm going to delete that and I'm going to think of what exactly is this behavior that I'm observing and how can I write about this person again in a more neutral, hope-centered way. We also want to emphasize again that recovery-oriented notes can still meet your funding requirements. This doesn't mean forego everything that your funders are telling you. It still includes being objective. It still includes measurable outcomes. It still includes documenting the services that were provided to demonstrate progress. But we ask that you reflect on some of these questions as you are documenting. And maybe we have a few minutes. Think about if there's something that was a helpful takeaway from today. Before you go, don't go just yet because there's a few more slides. But think about what language habits will I change? What checklist area do I want to strengthen? And how can I model hope-centered documentation on my team? Like I shared, I will share these resources with you. And I wanted to also share a link to our evaluation. We'll put that in the chat for you. I do see the comment, finding it hard to balance meeting a client where they're at and working for a system that will punish them for non-compliance. I think, and open to others' responses, but a lot of this is the work that you're doing is building a relationship, and building a relationship is making progress. If we can build a relationship that might support a person's motivation and buy-in and support their ideas and interests to move forward and do something different, I'm open to hearing others' thoughts and perspectives. The evaluation is there in the chat, so please do take a moment to complete that. It is anonymous and helps us to revamp and update and make all things better for you in the future. But we wanted to thank you. We appreciate your time, attention, and participation. Today's webinar was hosted by DBHR through the Washington State Healthcare Authority. We'd like to remind you that the slides, link to the recording, and other resources will be available in the follow-up email. We also shared that in the chat. Don't forget to check out the FCS newsletter for all things FCS and upcoming training events and more information on how to become an FCS provider. If there's any questions, please don't hesitate to email me. I'm really just an email away and happy to support you in anything in the future. But with that, we are probably a few seconds away from the conclusion of our training. Thank you again for being here and for your engagement and kindness and excitement and willingness to contribute to the discussion. We do appreciate your openness to this conversation. No one's perfect. We're just out here doing our best. So thank you again, and we hope to see you all soon. Take good care.